Now, this does not mean that the patient is still hyperthyroid. It means that the patient is improving because you are comparing it to your earlier level. If you continue the same dose, in another month's time, you might find that the T3, T4 have actually gone a little lower than normal, but the TSH is still not elevated. It is still on the lower side. This patient is now showing you typically that the suppression is coming up slowly, but you need to reduce your dose. So you, in isolation, if you say then, what would be your temptation to call this report a low T3, low T4 and a low TSH? Central disease. But this is not central disease. It's a thyroid in transition. And the same thing happens after giving radioactive iodine therapy. You've given radioactive iodine, patient is improving, T3, T4s are dropping, the TSH has still not come up. Somebody labels this as, central and then gets an MRI or all such kinds of ridiculous things. But unless we realize that if you have earlier levels and if you compare them and you know what the patient is, unfortunately I know that you're in a fix because you don't necessarily know what the patient has, and I think it's a good idea to ask the patient what exactly is happening, because otherwise just interpretation of reports based on levels is impossible, particularly as very clearly mentioned on this slide, because it could be anything really. Unless we know what the patient is taking, it's not difficult. A little bit about thyroid antibodies. I think it's the fashion of the day to do antibodies, but we need to clearly understand what information we get from them. The only information that we get from antibody testing is to know whether this patient has autoimmune disease or not. Now, most of the times, I really don't need to know this also, because 95% of the times, thyroid disease is autoimmune, unless otherwise proven. And Shrikant is here, and we do get cases of, iodine-induced hypothyroidism or iodine-induced thyrotoxicosis, where it might be relevant to find out if this patient actually has a thyroid disease of autoimmunity or it is because of some kind of another agent which is being given to him. So there are some situations where testing becomes important, but otherwise it only reinforces the 95% garden variety of thyroid, which is autoimmune. Autoimmune antibodies are targeted against some antibodies of the components of the thyroid. The most relevant are anti-thyroid peroxidase antibody, anti-thyroglobulin antibody, and something which is not usually done, and that is TSH receptor antibodies, which I'll talk about briefly later. Anti-symporter antibodies, which actually are bound to the iodine internification process step, is available now. The relevance, the real difference between that and TPO is not known. Anti-thyroid antibodies, anti-TPO typically, is the hallmark of Hashimoto's disease. Now, Hashimoto's disease is actually a pathological entity. What Hashimoto described was a chronic lymphocytic thyroiditis with hypothyroidism. Now, we use it clinically to talk of a gland which is firm, which obviously has lymphocytic infiltration, and the surrogate of that is high levels of antithyroid peroxidase antibodies with hypothyroidism. So, anti-TPO is specific for the peroxidase enzyme. It catalyzes iodine oxidation incorporation into thyroglobulin. It's present in 90% of Hashimoto's disease, 75% of Graves' disease, and it is also present in nodular disease and thyroid cancer, mind you, but it is still more specific for Hashimoto's. But remember that up to 15% of normal individuals who will never ever develop thyroid disease in their lifetime can have antibodies. So testing antibodies as a routine screening should be stopped as part of executive workups or whatever it's called. So it doesn't make any sense, and there is unnecessary panic and paranoia. Now, as I said, it's most useful in diagnosing chronic autoimmune thyroiditis causing hypothyroidism, but sometimes it's useful in, as I said, differentiating Graves from other kinds of hyperthyroidism, like for example, iodine-induced hyperthyroidism or maybe amiodarone-induced thyrotoxicosis. What about TRAB? Now, TRAB is relatively specific for Graves' disease. Now, we use TPO for Graves as well, but what is really specific for Graves is TRAB, and this is particularly useful in some patients, especially if you have an eye disease, which you're not sure whether it's because of thyroid or because of something else. If the TRAB is strongly positive, it is Graves' ophthalmopathy. A mother who has had hyperthyroidism in the past, and if you want to know the risk of passing this particular problem to the fetus, the testing for TRAB will tell you that the fetus is at risk, and also, as I said, for differentiating Graves from other causes of thyrotoxicosis. Antithyroglobulin antibodies, I particularly feel, except in the situation of testing for thyroglobulin in follow-ups of thyroid cancer, have relatively no particular clinical value in today's medicine, and I think we should stop doing antithyroglobulin antibodies in other situations. If antithyroid peroxidase is done, you don't necessarily need to do antithyroglobulin antibodies additionally. Now, we were talking about TBG and just a few clinical situations here. Which are the factors which increase TBG and therefore increase the total T4 and T3 levels increase? But as you know, FT4 and FT3 remain the same. And then there are, of course, situations which are exactly the opposite. These are drugs which cause rise in TBG. And the most important is all forms of estrogen. So any person who is on oral contraceptives and by a corollary pregnant will have a raised T4 and T3. Similarly, these are not commonly used drugs, but we could remember them, particularly tamoxifen, because many postmenopausal women may be on this for breast cancer prophylaxis. And conditions that increase TBG, pregnancy stands right up there. And then, of course, as I told you, hepatic disorders, porphyrias, biliary cirrhosis, something important, could cause falsely elevated T3 and T4. What are the opposite spectrum? Drugs which reduce T3 and T4, the prime ones are glucocorticoids. So when a person is on long-term glucocorticoid therapy, you can expect reduction in T3 and T4 with normal TSH. All these people will have normal TSH because they do not have a disease. They only have a lab abnormality. And others, of course, salicylates is one which causes this particular problem. And any acute illness, as we were talking about, the sick thyroid syndrome will cause a reduction in thyroid globulin binding and therefore reduction in T3 and T4. Then there are some others which affect the TSH primarily, not just the T3, T4. And here there is a bit of a confusion. TSH going down, not very low, but lower normals, is very often seen in dopamine treated patients, bromocriptine treated patients, glucocorticoids, and patients on octreotide. So pancreatitis, octreotide therapy, TSH will go down 0.1, 0.2, and you are not sure what this is. Always look for drugs. Increase TSH, but generally not very high, less than 10. Amiodarone and metoclopramide. This is important. Metoclopramide is used so often, and just a 6 weeks course of metoclopramide for say GERD can actually raise the TSH. So be careful there. Increased free T4 is seen with intravenous furosemide. So the problem comes like this, that the patient is admitted for heart failure or some cardiac problems. Patient is given furosemide and the thyroid is automatically sent because the patient has had arrhythmia or is under cardiac failure for investigation, and suddenly you get FT4 elevation, and the cardiologist might want to know if this is actually thyrotoxicosis. But this is not. This is the IV furosemide effect. The same thing can be seen with IV heparin as well. And amiodarone can cause a variety of disorders, both hypothyroidism and hyperthyroidism, with varying effects on T3 and T4. And very importantly, if the patient is taking phenytoin and carbamazepine, very commonly used anticonvulsants, you will see reduced free T4. And that's because of excessive clearance of these molecules from the circulation. So be careful when you have abnormal looking tests without clinical disease, always look at drug causes.